Thank you. For those of you who want it, we can get closed captions, and they actually work really well for Zoom, which is nice. So here are the directions. And if we are only here very briefly and you need more directions, put it in the chat, and Ellie or Deodora are going to guide you through how to get closed captions for today's seminar. Next slide, please, Olivia. Just a reminder, our goal for this seminar series, as well as all the other activities we do, is to advance the science on recovery community centers and to do it together from the multi-stakeholder perspectives that we have. So working together, scientists, clinicians, RCC directors, RCC staff, policy makers, healthcare decision makers. We're trying to pull together all of you guys' voices to really work at issues from multiple perspectives so we can advance the science together. These good people here, some of them are in the room, are our steering committee who go over like what happens in seminars, what we do in pilot funding, what are our next steps. So you can talk to any of us for directions you have for us. Next slide. Our research, so we're all NIDA funded. National Institute on Drug Abuse is funding this project, which is exciting. We're focusing on recovery community centers. NIDA also funded other research networks that focus on other recovery support services and other questions related in this space. Altogether, we formed the Consortium on Addiction Recovery Science, and this is where Angela is coming from, who is in the room with us today. We all collaborate on a variety of things to help network, to help inspire, to help work together forwards. This is a really small microfiche slide, so I hope you enjoyed on Tuesday when we'll mail it out for you all to read. At the moment, I just want to highlight that we do have a very cool new special issue for journals. So if you are doing science in this space and you want to publish it, please consider submitting to the to this particular special issue. And I'm happy to take questions for it over email and in Zoom. So always reach out, and you'll have a slide for on Tuesday. Very good. Moving on to the next slide. Now, as I mentioned, we are focusing on recovery community centers. When we did our nationwide study about RCCs, we found about 200. Since then, we have tried to kind of loosely keep track of who else is out there. Our list now is about 400 RCCs, I want to say, and we want to hear about every one of them. So I see here people putting information to chat. Thank you. That's perfect. We want to add you to our list. This list is on our website, and I don't know, Ellie, if you can pop that link in there so you can see who's on the list and people can add, to that list. We want this because when we talk about RCCs to other secular groups, people ask, well, is there an RCC near me? And we want to say, well, it so happens that there is, and hand them the list. That's one purpose. The other one is that we want to do more science and involve you guys in science. So if you're on our list, we know to reach out to you to collaborate on research projects. So please let us know if you are part of an RCC that we don't know of yet. Next slide. All right, and with that said, we are always grounding ourselves in who recovery community centers are, and they are all different, they all share things, and they're all different, so it's always wonderful to see each unique one. Today, we are super happy to have Melanie Cobb with us from Landmark Recovery. Melanie, can you tell us what happens when you walk through the door of your recovery community center?
Hi, thank you so much for having me. When you walk through the door at Landmark Recovery Center, the first thing you're going to really come encountered with is the smell of coffee and just that wonderful welcoming atmosphere. You're going to be hearing people talk, and as you walk toward the sound of talking, you're going to be greeted by one of our staff. We have a staff of 5. 4 of them are peer support specialists, and one of them is a family member of someone in recovery. They're going to ask you to sign in and ask if you've been here before. Our sign-in sheet is directly in front of our big bulletin board that has all of our events going on, like like barbecues and fishing trips and float trips and all kinds of things. We have a volleyball tournament coming up this weekend. Anything that you can think of to have fun in recovery. Then if they say they've never been here before, we give them a tour. So they'll start walking through the building with one of our staff, and they'll be introduced to our staff. As they turn a corner, they'll see our lounge area that has TVs and computers and comfortable seating. They'll also come in contact with people who might already be in the RCC using our services. So they could see things like people working one-on-one with our peer support specialists. They could see people starting to head towards our meeting room for some of our groups. They could see people working on their steps at our tables. They could see people meeting with other members of the community that are part of their support team, like probation officers, caseworkers, community support specialists. Anybody who works in the field can meet with their people here. They might see people eating and enjoying each other's company. They might see people doing community service, and they might even see people coming and leaving, going back and forth to court or looking for jobs. They could even see somebody doing something like a impromptu interview to try to do a mock interview to try to get a job. There are so many things that can be done here. We even have crafting supplies available for people. And that's just if you want to be in the center. Then if you would like to work on anything after the tour and we find out exactly what they're here for and who referred them, then we'll find out if they want to do some more work one-on-one. And then we use our advanced recovery management system to work one-on-one to help them find out exactly what's standing in their way from rebuilding their lives. And we just start to get to work. And that's what it's like to come to Landmark Recovery Center.
Awesome. That is a lot going on in so many different areas. That's exciting to hear, Melanie. Thank you for sharing that with us. And we'll hear more from Melanie as we go on, and hopefully from all of you, because I think it's a topic that that many people can chime in, all of us really. So move on to the next slide. I do want to set the stage. As you all know, well, we'll do the polling questions first, but there'll be some preview there. Our goal here today is really to learn about the workforce, the people who are making the recovery community centers into the great places that they are. So we'll do our polling questions now. If you want to start that, Olivia, this is demographics about who you are, so we can see who we are reaching and who we're not reaching in these seminars, and then some preview questions about the content that is to come. So if you take a moment to answer this, and once you're done, you need to scroll down on the right-hand side here. And once you're done, the submit button at the bottom turns blue. So let me do this too, so I can. You can see that there was a long item at the bottom for the various tasks, and a peer recovery support specialist may or may not be doing at an RCC. Curious to see what you all think. Olivia, how are we doing on completion?
We're at 55%.
55, great. Our goal is to get to about, what was it, 80%, 70, 80% is usually what we hope for.
Yeah.
So it'll give people a chance to complete. And those of you who are already done with your polling questions, this is your moment of zen for the day. How are we looking?
Just hit 80.
Perfect. All right. We can share the results. I think this is for everybody to be able to click through. So I'm going to jump right down to the questions that are previewing what's to come for today. So we asked about how many paid staff do you think work on RCC in average? And I see lots of responses for 5, which is what Melanie mentioned for us. And we'll talk more about that in a little while. We asked how many of you were aware of the SAMHSA's national model standards for peer support certification. And most of you are. Very cool. And I'm curious about you guys' thoughts on it. So when we get to that part, please chime in with your thoughts about, those standards and how it's impacting your part of the world. And then we have a question about the many different tasks. And the top ones that people thought was leading groups and have individual sessions of participants and be present and welcoming. Don't let other people be invisible. Communicate, interact with the criminal legal system, connect with government and community resources. That's actually the number one, 91%. Help find jobs, help find housing, data input for grant funding and paperwork. Actually only has 68%. And I think the ever lowest ones, we have buying daily goods, assistance of prescriptions. So of course, the answer is that all of the above is true. But it certainly depends from RCC to RCC, and Matt and Kevin are going to tell us more about that. All right, so to set the stage, Olivia, if you can move us to the next slide. We just wanted to share some papers with you all, and Ellie will put them in the chat for you guys who want to download them, to say that the empirical literature scientists have collected some data on the peer recovery workforce and have deemed them an integral component of a behavioral healthcare system. And that's pretty ancient. I don't want to say ancient, but it's published in 2016. So that awareness and knowledge has been around for a long time, as have been the struggles that is encountered by this workforce. So there are the struggles that were reported in 2016, and we will hear from Kevin and Matthew and Melanie and anybody in the room who wants to chime in about whether or not they're true today. Struggles that were identified back then are discrimination from non-peer staff, lower pay, role conflict, ambiguity, and boundary issues, and lack of a specific job description. That was sort of like an evolving thing. So those are the issues and the struggles that were noted about 10 years ago. In terms of like who was studied in the years, so this is a more recent paper, but the most knowledge we currently have about the peer recovery workforce is from places that are located in like the Veterans Administration, medical and outpatient facilities, as well as some community clinics. So these settings are typically integrated care teams that the peers are integrated into a clinical care team, which is different from a peer-run organization. Next slide. So this is where we are very fortunate to have Angela in the room. So Angela, can you tell us, if you wouldn't mind, who the 659 people are who were asked to answer this question?
Yeah, certainly. So this was a convenience sample of certified peer recovery support specialists in 9 states of the US. It was disseminated by state certification bodies, state level associations, national level associations. I don't have in front of me open which of the 9 states, but the 659 were certified peers internationally, nationally, or state level certified peers in 9 states of the US.
Perfect. And Ellie just put the summary of that study into the chat for you guys to look at, which was great. The important part for us to think about here, when these 659 people answered this, only 25% of them, only a quarter of them said that they were actually employed by a not-for-profit community organization, by a peer-run organization. There's a lot of other places in which peers were working, notably the behavioral health community mental health area, which is exactly what we saw on the previous slide in terms of what we know in the literature about this workforce and how they are employed and the challenges they're encountering. RCCs are special places. Peer-run organizations are different than non-peer-run organizations, which is why we wanted to do our seminar today, to really highlight what it's like to be working at a recovery community center. All right, next slide. So we asked you in the polling questions about how many, like how big are RCCs? How many employees do they have? How many paid and non-paid staff do they have? So this is from our nationwide survey study that we did with the help of many of you on this call today. And if you take the average, and averages are, of course, they're not misleading, but they only capture so much. There's some that are much smaller, some of them that are much bigger. But on average, we're looking at about 9 paid staff per recovery community center and about 10 volunteer staff that are also supporting the work of a recovery community center. Now, this is not in contrast to, but this is in relation to the folks who are actually walking through the door. And here we actually use the median because the numbers are there was a large range of how many people walk through the door. But on median, within a year, 500 different people would walk through the door of any one of these RCCs. And actively, like on a coming in any given month would be about 125. So think about those 8 staff members who are paid and the 10 volunteer staff members who are supporting and interacting and making welcome the 125 folks a month or the 500 different people across a year. All right, next slide. Here we just wanted to provide, for those of you who haven't seen it yet, the SAMHSA's National Model Standards for Peer Support Certification. We have a link in the chat or the PDF in the chat even. And they provide standards in terms of training and certification, which talk about what kind of authenticity and lived experience would be needed to be qualifying as a peer in the space, the training that should be offered and given, the examinations, what kind of formal education requirements should be met, how much supervised work needs to be done, what should be part of a background checks, details on recovery, diversity, equity, and inclusion, ethics. And then also the last 2 pieces, which we'll also get to today in terms of peer supervision, to what degree are you supported in the challenges you're encountering, and then the costs and fees for all of these programs. So it's a great document to look at. And if we go to the next slide, we actually asked about, the recommendations for how to cover costs and fees, because training is expensive. Taking time out of your schedule to attend to trainings is expensive. And we just pulled some information here where we heard about, yes, that there is a desire, but it's really challenging at the moment anyway, to have these resources be paid for. And I'm sure there's progress being made. And if you guys hear about things of like, I know a resource of how you can get this paid for, please let us know so we can share that information with others. All right, I'm moving us on to our moderated discussion today. Kevin, Matt, I'm super excited that you're here with us today to shed some light on what is it like to be a peer recovery support specialist. And we will, here you can see so Kevin is a recovery coach at the Rhode Island Communities for Addiction Recovery Efforts, VICARES, and Matt is the program coordinator at the Tri-Cities Recovery Community Initiative. And I don't even know what all those acronyms are, to be honest with you, for your titles. You'll have to tell us about those, Matt, in a moment. All right, if we can do stop screen sharing so we can actually see each other. My first question to the 2 of you is if you could tell us, what does a typical day, if there is such a thing, or a typical week look like in your life and in your role?
You want to take it first, Kevin?
Okay, when you use the word typical, that's a little bit of an understatement. I think there's a routine that I have every day, and Melanie kind of hit on that. The smell of coffee, the volunteer coming in, and just things that take place every day. The routine is usually to come in, check my emails, check what's in Teams to see which staff is going to be late or whatever may be happening on that day. And then to go into my files and looks to see who needs to do, I need to reach out to, who's working, sober houses, and what's going on. But the day is very flux, it's very malleable. The day is very malleable because of the environment in which our RCC is. And we might be dealing with somebody outside that's laying on the sidewalk. We might have people coming in where you have to make a decision whether you're dealing with a mental health crisis or you're dealing with somebody that's active in their substance use or whatever the case may be. So it's very fluid. It changes constantly. I mean, I hope to have that typical day sometimes. And the typical day or unordinary day is just when it's quiet. You know what I mean? Mm-hmm. Here in Rhode Island, it seems like to me, because I've been doing this about 4.5 years, and it seems to me that the individuals are seasonal. It's a very seasonal thing. And what I mean by that, the needs, the capital that they don't have, that they need in the winter, it brings them into the center. And so when they come into the center, whether they're coming into the center because they're looking for clothing, they're looking for something to eat or a place to stay, that's where, as a coach, if there is a substance use problem there, we try to get into that breach where it's broke. We try to get into there and we try to get them to talk about recovery, talk about the different things that they that we could help them with. First, basically trying to find out what their needs are. And then we have individuals that come in and you're dealing with a whole lot of different personalities for me, you know, but I know that my lived experience brings in the humbleness where I have to be humble. You know, I have to be very humble in this work. It's a work that has taught me several different things, and I try to use those on a typical day. And that typical day was do no harm. You know, when you're taking care of individuals, understand the boundaries that have to take place and how far you can go and how far that you can't go. And sometimes because we're dealing with life and death, and we're dealing with homelessness, and we're dealing with broken hearts, so to speak. When you're dealing with that, sometimes it can kind of take down the boundary. Sometimes you want to go that extra mile, you know what I mean? Because, and the reason why I say that is because it's people that went that extra mile for me, you know, and I'm not just talking about people that came and kind of threw me a life preserver and pulled me out of the drowning waters. I'm also talking about people that I work with, you know, how they cared for me. I didn't know how to take care of myself, but now on a typical day, I do know how to take care of myself. It also involves, here at Right Cares, it involves doing groups. You know, we do a lot of groups here, you know, in the groups, we give information, but we also, and sometimes in the groups, we try to give answers, you know, because I understand now that capital is more than just something that's outside of us, you know. And one of the things I learned in this work is that a lot of us, including myself, that I'm dealing with that has substance use disorder, how to develop patience and how to help somebody get to that next goal, short-term goals, long-term goals, whatever they may be, you know, and how to restore some of the mental capital that we do need to be successful in this. So basically that's what it is. But when you say typical day, you know, I pray for those. Routine day, yes, I have those, and it's a routine that I follow. And then there's the day of reality. And that day of reality is there, is up front, you know. In the area that we're in, we do a lot of hard work. This is really what you call here, boots on the ground, you know. And so we're very heavy with the boots, and we do it, but we try to do it in writing on a spirit of love.
Great. Thanks, Kevin. And Matt, does that sound similar or different from your experience?
Pretty similar. I don't think there is such a thing as a typical day. I work at Detroit Recovery Project right in the heart of the city. There's constantly something going on outside the doors, inside the doors, down the block. Luckily, where I'm at, we have wraparound service, everything from primary care, psychiatric services, peer recovery, outpatient, things of that nature. So we have people on staff that are educated in different areas that can deal with different situations that we have. Today, my day started off, I had a 2-hour all staff meeting from 10 to 12, and then I'm here for this. And now I have group when I'm done with this, and 1 intake and 2 individuals. A day can look like that. A day can look like me going out and doing outreach, trying to bring people in the doors, just partnering up with different organizations, vendoring tables at events and things like that, trying to make contacts and get the word out there and let people know that recovery is possible. As far as getting them in the doors, once we get them in, you know, they're pretty good about coming to group. I usually do groups 2 to 3 times a week. We offer them every day of the week over here. So we have 6 other recovery coaches that are doing groups during the week as well. But I mean, it can range in a number of different ways from whatever I have to do from Monday to Tuesday. It's never a definite, and it's always in flux.
Right, right. And so you mentioned also that you're part of a larger organization, that you do have some other teams working alongside you. So actually, if we can highlight Melanie and spotlight her as well. So Melanie, you mentioned that yours is a smaller RCC, right? So Matthew, how many people, paid staff, do you think would be, if you had to guesstimate, our DRP?
50, 55.
Mm-hmm. So that's different from Melanie, your experience, right? Because you're a small team who has to make many things happen in that small team, right?
Right, absolutely.
And Kevin, how does YKS fit in? Like, how many paid staff do you think you have? How large is your team that you're working with?
Okay, I'm gonna say average, I think it's 5 or 6 right now.
Mm-hmm.
And because everybody, you got right now we have 2 coaches, and then when you're dealing with the 2 coaches, then you have a lot of peers coming in, you know, and so we deal with a lot of different things as far as that is concerned when it comes to coaching, and it's such a continuous flux of things and people coming in all the time, whether it's groups, you know, so one of us is running groups, another was back at our desk, we're trying to do follow-ups, then you got people coming in needing housing, needing clothing, some just needing something to eat. And so trying to spread yourself, it's a task every day, you know, and I can't speak for others, but I actually feel it now, you know, and I feel it because it's work, you know, it's work. I remember when I first, the job was presented to me, I know how I wanted the job to look. You know, I wanted to, you know, I thought I had the magic touch, you know what I mean? I thought I had the healing hands, you know, and it's not that simple, you know. This is really, really work. This is one thing when I'm talking to a lot of my peers, I talk about, and here at RIKIDS, you know, we're actually out here trying to save lives. When it's all said and done with, that's what it's about, you know. And when you have a small, intimate group like we have here at RIKIDS, I mean, we got to pass it on sometimes, you know. And my director, she told me just one day, and I mean, I knew it, but when she said it, it really rang the bell. She said, "Whatever you do, don't do no harm. You know, don't do any harm." And that's the thing that keeps those boundaries around it. But yeah, we got I think we got 5 paid staff here, but we do have volunteers too.
And Matthew, Melanie, for you guys, was it also like, did you know the job before you had it? Like, or now that you're in your respective roles, you're like, wow, this is different than what I expected.
Speaking for us, it definitely turned out to be a lot more harm reduction focused, and that's okay. You know, we came into the community, we were, you know, we just wanted to help all the other organizations out there and try to fill the gaps to keep people from falling through the cracks. And so we reached out to all the different organizations and tried to figure out what, you know, exactly everybody was lacking, and if there was any way that we could help. And so far it's been a lot of harm reduction and connection to resources.
Great.
For myself, there were a lot of things that, I mean, we really had, I know we're going to talk about trainings, but we have a lot of extensive trainings that we do in Michigan for recovery coaching. And none of them really prepared me for what I was getting myself into. What you learn in the classrooms and over the Zoom meetings and stuff like that totally goes out the door when you have the people in front of you that are, you know, you're the only person standing between them and living in the streets for the night, or getting them something to eat, or just giving them hope that they can make it another day. And then after being in the recovery coach role for a while, I also had to split time as like project coordinator. So there were other things that came into play that, you know, you're just not trained for at the time. And it's kind of baptism by fire kind of thing that you have to learn on the fly and fit into that role. The recovery coach, all the trainings and everything like that, there's a lot of things that play into the role on a daily basis, but there's a lot of things that just aren't covered.
Yeah.
So the answer is short, no. I wasn't fully prepared for what I was getting myself into. It's a labor of love. You figure that out real quick.
Yeah, no, I can see that. And, like the juxtaposition of like the list, like we also have a long list in the polling question. This is what you guys generate on Tuesday, but all the different things that you guys do. And that's juxtaposed of, the one item that we had in there from you, Kevin, about, don't let other people's be invisible, which all of you guys spoke to about really being there with a person that you are seeing, that you are greeting, that you are guiding. That is so tough to do when you're being pulled in so many different directions. You have so many different things. How do you balance that? How do you balance being present with having so many different hats to wear and so many different things to do?
Yeah, I think for me, I think it's knowing my lane, knowing my limitations, and when I was not doing this work, I didn't know my limitations. My work is not my recovery. It's not my recovery. And I learned how to separate those things, the salt water from the sweet water, so to speak. I have to understand that when I see what I see in front of me, whether it's homelessness, someone that's hungry, substance use, or mental health, when I see those taking place, I have to remember, but there go I. I was homeless, I was hungry. I was out there. So that lived experience. And so when I see it, what I don't know, I don't touch. You understand? So I'm not going to do no harm. I know to reach out and get to assistance, having the right phone numbers, who to call, go to my director, go to my supervisor. And I don't know how to do this, but we keep it safe. And then we do that brainstorming thing and we do the next best thing that is safe for the individual. And so I have to know my lane. I have to know who I am. And before I started doing this work, I didn't know who I was, and that's real talk for me. But this is the work in general it's like Matthew said, it's a labor of love, you know what I mean? And in it you get, you have to be careful because you get that broken heart, you can get that broken heart. You can get wounded, you know what I mean? You can get wounded. So you really have to know and you have to take care of yourself too. But I know my limitations now. Before I didn't. I just thought, I can do this and people are going to listen to me. And the reason why they're coming up in here, when they get done listening to me, everything's going to be all right. And sometimes they just, they just there all the time. And I have to watch my level of energy, because sometimes I get caught up in that cookie cutter thing. Somebody comes through, or they ain't here, they just want something to eat, or they just want housing. They're not here about recovery, and I have to be very careful to try to read people and what their intentions are. So I think it's a very, like I say again, it's very valuable, it's very fluctuating, and to be able to hold on to me as a man and as a human being and to care, you have to have a lot of wellness, and you got to have a team around you. A team can be 2 or a team can be 50, but if you got a good team, it's going to happen. You know what I mean? We're going to look out for each other. So yeah, I know my position. I don't try to get outside my lane.
Great.
I think that it's also really easy to just keep in mind that it's completely person-centered. So you can't follow a cookie cutter process if you don't, and you just need to get to know the person. So you keep them at the center, the very, very center. You can't, for us as peer support specialists, we can't go anywhere until the person says they're ready to go. And I think that's how we keep it just straightforward.
Yeah.
For myself, I think I had to come in and learn boundaries. I came into my recovery a few years in before I became a recovery coach, and I was on fire for the job. And I came in and I was trying to be everything to everybody. And real quick, people expect that of you, and it's hard to keep up that level of service and stay inside your scope of work as a recovery coach. And boundaries not only with workers or employers, but with the clients as well. Because, sometimes they'll want to call you 1 o'clock, 2 o'clock in the morning with whatever they're going through and stuff like that. And if it's an emergency or something like that, I mean, I understand it, but some people will get a little comfortable with the phone calls and take it a little too far and try to push those boundaries a little bit. And unless you have them firmly set in place, we all know how, you know, people that are in active drug use or fresh out of active drug use are manipulators. Me being guilty of that myself when I was in my addiction. So just being able to learn how to share myself enough and do the best that I can within my scope of work and perform to the best of my ability for my employer, that was a feeling out process for me.
Mm. Yeah, and so this is definitely, I mean, all of you are mentioning how much being in your role and experience it kind of is helps you set your own boundaries, see your own limits, and move forward in a way that keeps you together. Now, we've talked a little about training, and can you guys talk a little bit? You have mentioned already a little bit, Matthew, and Kevin, if you also want to chime in, and Melanie, what kind of training you have. And while you're talking about your training, like you mentioned Zoom meetings, Matt, about like they're not great. Obviously, I love Zoom. You know, I love seeing all of you guys here and for all of us being able to come together to talk about these things. But what would ideally be something? So what is something that you didn't get in training that you would have liked to have, or a support that you would like to have that you don't have? Like if you can also speak to that. The training you got versus the training you wanted, or ideally would have had. Who wants to go first?
I would have liked a little bit more training on behavioral health disorders and specifically the mental health side. I think that would have been really helpful considering how much co-occurring goes on.
Mm-hmm. Great point. There's a lot of that.
So for myself here in Michigan, and it might be an organizational thing, but I think it's pretty much statewide. We have what are called DWC trainings, which are separate from Improving Michigan Practice trainings, which are separate from Relias trainings. We have 37 trainings in total that we have to keep up either on a yearly or bi-yearly basis to keep our certification. So after we go through the CCAR, which was the 46-hour training, we have to start on all these VCEs and do all the Zoom, the webinars, the different things through Detroit City, Wayne County, the state of Michigan, because we have to hold dual certifications in order to bill for groups and individuals in Michigan. So we have to have CPRM, which is Certified Peer Recovery Mentor, and CPRC, which is Certified Peer Recovery Coach. So in order to attain those, we have to keep 100% of our trainings up to date.
And does that feel like the right level of training for you? Too much in between? I mean, how does it feel on your end?
It's a little excessive. I mean, there's a lot of things that are applicable to what we do, and then there's a lot of things that are just like, you know, the fire safety and the biohazards and things of that nature, where we're not really faced that on a daily level, but we still have to do the trainings yearly on it. So I think some of them could be eliminated. They could put some other things in there, like Melanie was stating, like towards the behavioral health, because co-occurring disorder is so prevalent. You know, I think they could do a better job of tailoring it towards the position of what we're doing as far as the trainings that they administer.
That makes sense. That makes sense. Kevin, does that look similar on you? Do you also have to upkeep these certifications on an annual basis?
Yeah, in Rhode Island, yeah, some of it, yes. One of the things I wish I could have got more of, I have some of it, would be mental health and how to distinguish some of the behaviors from mental health to the substance use disorder. And sometimes I get caught up in that blending of the two. And I'm using the tactics, or I'm using the skills or lived experience of my mental health condition, so to speak, or my substance use, so to speak. I'm using that. I think a lot of how I do my work is through lived experience, and then a lot of it is OJT too. It's coming in, and I actually find my way in a through on-the-job situation. I never, for example, I never seen myself before I started doing this work, speaking to students at Brown University and how to speak to people, how to present myself on that level. I never pictured myself going to the State House and speaking to Congress and speaking to Senate. I didn't see all this coming in, you know, when I got this job, and I do some of that. I do a lot of that, and how to be in that atmosphere, because it's just not dealing with with people with substance use disorder. It's also being here today on this panel.
Yeah.
It's also that, you know, and this is something that's coming. This is the job presenting situations and presenting life to you, you know, and this is part of it, to be able to sit here and to understand that after meeting there's doctors, there's scientists, and people that might, when we break off, want to ask me questions. You know, I wasn't trained for that part, you understand? And it's just something that developed, you know. But when you're doing this recovery work, on for real talk, sometimes you talk to people that you never talked to before. Sometimes you're not just talking to an individual that got a substance use disorder, or you're talking to somebody that got a mental health disorder. Sometimes you're talking to somebody that's holding a doctorate degree. Sometimes you're talking to people that are going after their doctorates, they're going after their masters, you know. I mean, I was in a group and I was with some students from Brown University who were writing an article or writing a paper how to advocate for medical insurance, you know. And when they called me, they had me, I was working with these teams, and these teams were asking my opinion about how do individuals advocate? How do they look at discrimination? How do we advocate for them? How do they advocate for themselves? I didn't see, this is all part of it, you know, and you know the tree by the fruit it bear. So when it comes to training, the training is there, you know, as far as the mental health and substance use. I had the ethics training. I know how to say, thank you, please, excuse me. I know the boundaries. And sometimes when I stay within the boundaries, I have to train myself when I'm in the boundaries. I'm not saying no, I'm taking care of myself. And sometimes I used to feel really bad when I didn't break the boundaries. Like Matt was saying, when I didn't answer the phone at 2 or 3 o'clock in the morning. You know, I felt bad that I left somebody out there hanging. I felt that maybe I done some harm, you know. So when it comes to training and you're a recovery coach, understand the game, this is real work. And sometimes you're dealing with people that I've never expected to talk to, you know, and that's not a training thing. You know what I mean? But I'm learning, but I mean, when you're a recovery specialist, they don't tell you, you know, one day you might be sitting on a panel and doctors and scientists and psychologists and psychiatrists are going to be listening to what you say. This is real work, you know? And and because of now, where I'm at in RICARES, because of the team and the director that I have, I'm learning a little bit more. My brain is a little bit more organized, you know, and when you say lived experience, the training is one thing, but now I'm getting to live experience. I'm listening to my team. I listen to my colleagues. I listen to my supervisor, and I listen to what they say. And then I try to sometimes implement it. If I don't know it, ask questions, you know. And where I have my shortcomings, they know where I'm soft at. They know where my game ain't tight. But what they do, they cover me, you know, and when they cover me, they make me feel safe. That's the best training in the world. But there's other training that I would like to have, but it's amazing work, you know, because I never pictured myself doing this. I'm telling you this, you know.
And of course, you gave it a perfect thing where we're saying answering questions, because George had a question in the chat here for all of you guys. If you guys can speak to how is your role, peer recovery support specialist, different from clinical case management? George, am I saying your question correctly? Because it's scrolled up a little if you want to speak up and phrase it.
Yeah, that's perfect. Thank you.
I think this is Kevin again. I think from clinical work and from peer work, clinical work, I think when people are doing clinical work, this is what I feel. I'm just flying out here now. You got me started. I feel that clinical work is one-sided. And what I mean by that is one-sided. It's not, when I'm doing peer work, the peer sees what I'm doing. He sees my screen when I'm working. When I'm asking questions or doing GIPRs or something, he sees the questions, he gives the answers. We share and we build together. Clinical work, the clinician has all the information. And some of that information he might not or she might not share with the individual that they're dealing with in treatment and doing the clinical work with. So I think that's just my opinion. Now I'm flying here, so y'all, you know, help me out. But I think that clinical work is way different. When it comes to clinical work, you got to have a lot of information and you got to go get the information. My information was given to me. It was given to me through my life experiences. It was given to me through different systems, being caught up in the system, and then my life becoming healed, or me being fixed, or people taking care of me. And it was other peers that took care of me. My healing didn't come at the healings of a person with a doctorate. My healing came through another peer recovery person. My healing and my life started anew with somebody that had lived experience. That's how it came through. It wasn't a clinician. It wasn't a police officer, and it wasn't a mental health worker. It was people that had substance use disorders, had mental health or due diagnosis, and they shared their experiences with me. And when I seen their lived experience, that gave me hope. And abracadabra, here go Houdini, it worked. And that's very important. So with the clinical work, it's a little different, you know, and we as peer recovery specialists, and when we're out here doing this work, sometimes we find ourselves doing clinical work. We find ourselves doing that. We find ourselves trying to talk someone down, you know, when they're in a mental health crisis, until the handlers can get there and handle the situation. So we're in that gap. Sometimes we're the first person they see when they're in a mental health crisis. And then we have to do the right thing and know how to pass it off, know who to reach out to, you know, and it happens right outside of our door every day. So I think there's a big difference between clinical work and peer work. You know, clinical work, listen to me, and here it is, and Matthew said it real good. The clinician get up and go home. We get the call at 2 o'clock in the morning. We get that call at 2 o'clock in the morning. We'll get that call at 3 o'clock in the morning. We'll go to a NA meeting. We'll go to an AA meeting. We'll take that walk for the cup of coffee, or go to a Dunkin' Donuts just so they can have some well time and be able to talk. Clinicians don't do that. I don't think so. You know, bear with me, but I think there's a big difference in that.
What about from your perspective, Melanie and Matthew, the differences between your role versus a clinical case management role?
Matthew, do you want to go first?
Yeah, I'd just like to echo what Kevin said. I mean, I think it's the lived experience is the game changer. I mean, that's what builds the bonds between peer recovery coaches and the people, that they just, a lot of them don't feel comfortable getting into with a therapist or a psychiatrist or a clinician of any sort, because they don't trust them to have the right opinion, because they've never been in the situation that they're in at that point in time. I've been there. I spent most of my life in addiction. Thank God I've got almost 8 years clean, and I feel like this is right where I'm supposed to be. I've lost almost everybody in my life to addiction or the violence associated with it. And if I can save one person from going through the heartache and the pain that I've gone through, that's what I'm here for. And I try to relate to everybody equally that comes through the doors to see me, and let them know, like, I'm here, I'm on your side. I'm not a probation officer. I'm not a parole officer. I'm not a therapist or anything like that. Like, I'm a person that has lived experience in addiction. I also have lived experience in recovery. So it is possible. If I can do it, anybody can do it. And you form that bond with the people and you earn that trust. And that's where the good stuff comes out. You know what I mean? And that's where the healing can begin, and they can start to work on themselves.
Melanie, same for
I
you?
think, yes, I think that, you know, I explain it to people usually this way is, you know, a caseworker will take you to go and sign up for housing, but a peer support worker will take you to go sign up for housing, and they'll talk with you the entire time about how they can relate with you. And I think it's all about how you can share your personal story throughout the entire process and really make those connections that I think there's a lot of boundaries that clinicians have to have that we don't.
Right. Virginia in the chat was saying, actually, Virginia, why don't you speak to that point? I don't want to use your words. Virginia's not. So she was, go ahead.
Hello. So, yeah, I was wondering how you learn to share your story to support others and to do it in a safe way and an intentional way. So I was just curious about that. It's not an easy thing to do. I think that, you know, people just assume because you have lived experience, because you've done that in other places in your life, you can just do that now as recovery support specialists. But I think it might be a little different. So I'm wondering, how do you learn to do that and keep it safe for yourself and make it targeted and intentional? That's my question.
Great question. Thank you, Virginia. And that builds right on what Melanie was saying. So Melanie, do you want to take it first?
So for me in particular, I learned how to do that through a 12-step fellowship that taught you how to take responsibility for your actions and to find the positive in it and use it to help other people. So I feel like I had sort of an advantage when I came into the field, where I already had a lot of practice with doing that. And then for the people that I hire, I'm looking for certain things when we do our interview process. I'm looking to see if they still have a victim mentality, or you know, certain things that would keep them from being able to say, this is what happened, this is where I am now, and this is how I got there. Just as simple as that. And then I can teach somebody how to be, you know, encouraging. You know, I can teach somebody and really form them once they get hired. But there are some people who really aren't ready to be peer support specialists just because they have some sobriety.
Mm-hmm. Kevin, nephew, how are you using your story? How have you learned to use your stories in a way that works, that you feel safe?
For me, I'm sorry, Kev, go ahead.
No, go ahead, you go.
I didn't use a 12-step program to get clean. I used medically assisted treatment, and just really kind of did a deep dive on myself and tried to work on the person that I was, without really realizing it. Years after the fact, I was actually working steps that you learn in a 12-step program, but it was just not applied that way, not presented to me that way. Once you shake the shame and the guilt and the stigma that goes along with being an addict or a person in active use, it becomes easier to share what you've been through, what you've done, decisions that you've made, things you've encountered. Once you come to terms with, this is the person I was, this is the person that I don't want to be anymore, and this is the person I am now, and I'm moving forward as this person. I'm not ashamed of my past because it made me who I am today. And if it offers even a glimmer of hope to someone else so that they don't go down that same path, then I'll scream it from the mountaintops. You know what I mean? And we were taught in classes that use our story sparingly. So it's not like we come out and we just wear our heart on our sleeves and throw our whole story out there when we encounter somebody. If something applies to a situation that they're dealing with, or you can make a reference to something, and depending on the relationship that you build with them, you can be more comfortable and share more if you want to, but use it as needed.
Mm-hmm. Mm-hmm. Kevin?
Yeah, I think I learned, I fell backwards, and I didn't fall backwards into the story, but how to tell the story. Because the story itself, as far as my biography is concerned, it's a very painful story.
Mm-hmm.
It's beyond, you know, and when somebody had heard my story, that's what got me in this position. I was actually working in a vegan restaurant, and I was talking to somebody, and they heard a little bit about my story. I was working up at Brown University. They heard my parts of my story, eavesdropping. And they was eavesdropping, and they came to me. They said, would you like to come in? And went, but they taught me how to tell the story. The story is very precious. My story is precious because it's where I'm sitting at today. The choices I made, I'm not proud of, but the man I am, I'm thankful for. And that path that I took, and now how to tell the story, to understand. One of the things I try to do when I'm telling my story, know my audience. Try to know who I'm talking to. Try to understand that, because I can have a peer in front of me that is the opposite of me. Sometimes it's not what you're saying, it's what you don't say. That is the lifesaver. And I listen very intently. You know, I listen to what individuals are saying. And should I say this much to them? And then how I present it. How do I package it? How do I package the story? It's learning skillfully how to tell the story and how to tell the story. I've read a lot of autobiographies of different great people who lived a rough life, you know, but how they told the story. Beautiful story, the story of Gandhi, beautiful story. It was a beautiful story, a story of nonviolence, how he did it, and then it was imitated by another man, Dr. Martin Luther King, for example. But when you look at the story itself, it contained violence. It contained a lot of different things in it. But how you read it, when you read it, people like that example. It's how you tell that story, how it's packaged up, because it's all in the presentation. It's all in the presentation. And for me to understand that my story, my life is precious. The path I took was a rocky path, but I'd say something. I look at myself today. I like myself. Am I ashamed of my story? No, it's not a war story. It's not a bragging story. It's who I am and who I probably will be as far as my past. I'm a different man today because of that path. I didn't, and I just want to share this. I didn't walk into my manhood. I didn't walk into this here. I didn't have a guy on the other end, man, playing catch. I wasn't in the Boy Scouts. I didn't play Little League Baseball. When I got my manhood, and listen very carefully, I fell ass backwards into it. And that's a hell of a way, but I got back up. And it was lessons learned. And so when I see a young man, just using that as an example, I can see myself. And now how do I package it? And when he says, wow, that happened to you? Then I can tell a little bit more of the story, but it's all in the packaging. It's all in the package, it's all in the presentation. And if you bring your story on a garbage can lid, too many people ain't gonna eat it. But if you bring it on China, you bring it right, and you bring it and you present it, then people can go for it. Wow, this really works. It's all in the presentation. And for me to understand, just like I tell them, when I tell my peers and I'm working with my peers, I say, understand where you're at today, sitting in that chair. Your story is precious. You can save lives with this. Look who they come to get when they need the work done. They come to get lived experience. Why don't y'all come in and do it? Because we don't know how to do this part. We can get the data, we can get the other stuff. We can change and try to change policies, but to change policies, I need you on the ground to do the work so we can get the results. See, what you're doing is going to bring the results. Are they returning back to prison? Are they returning to substance use disorder? Are they returning to domestic violence? It's us that is trying to make that change. Y'all, some of them are just getting the data. And so that's, it's when how we tell our story and how we present it, and we protect ourselves and we don't do harm to others with our story. So for me, it's knowing my audience. It's knowing my audience. And I say, thank you for my story. By say, thank you for my story, I'm saying thank you to my life. And I'm saying thank you for me being here. So I'm very careful with the story, but I try to know my audience too.
Yeah. Lots of love and appreciation in the chat here for you all. I will say it is 1 o'clock. We do have another half hour after the meeting, but we're going to stop our recording now.